think we started recording. So welcome, Dr. Grudzen. Thank you for taking the time to meet with us. Maybe we'll start with introductions. Dr. Grudzen, do you want to go first?
Sure. So, Corita Grudzen, I am an emergency physician at Memorial Sloan Kettering in New York City, and I run the Division of Supportive and Acute Care Services and a Center for Cancer Care Innovation. Nice to meet you both.
Great, thank you. Kristen, do you want to go?
Yeah, hi guys. I'm Kristen Keown. I'm currently in my third year of health sciences at Queen's University, and I got really interested in palliative care as actually a volunteer at Providence Care Hospital, and I really was interested from more of an academic side, so I reached out to Dr. Matthews, and now we're here.
Great.
Thanks, Kristen. And I'm Gene Matthews. I'm a palliative care physician and researcher at Queen's. And just about the time when Kristen had reached out to me, I came across your paper, Dr. Grudzen, and so I thought we could do a kind of a deep dive into it.
Mhm.
So just to kind of highlight the paper, this is palliative care initiated in the emergency department, a cluster randomized clinical trial. This was published in JAMA, um, I think a couple of months ago. Is that right? March?
January?
January.
Yeah.
Yeah, it was published in January. So before we get into this paper, I actually wanted to briefly talk about one of your earlier studies of palliative care initiated in the ED, which was in 2016. This was another randomized clinical trial. So can we start there, Dr. Goodson? Can you just briefly kind of talk about what that paper was about?
Sure, sure. So that was I did a single site randomized controlled trial of early palliative care in the emergency department in advanced cancer. It was done at Mount Sinai. And what we did is we randomized, that was a time when palliative care wasn't standard of care. And so we randomized patients who came into the ED and were being admitted to get a palliative care consultation, holistic one versus just standard of care. So the standard of care for the most part at that time was not a palliative care consult, but some patients did get a consult, days into or weeks into their admission. And what we found was that something as simple as ordering a palliative care consultation could improve quality of care months later in patients with solid metastatic cancer. And so what we thought about was, well, this is great. We know that what to do in patients that are admitted that have a lot of palliative care needs. We should get a consult, at admission as soon as possible to improve quality of life. But what do we do about patients that are going home? That was kind of a gap. We couldn't just, at that time, there wasn't outpatient palliative care, was not, it wasn't easy to just refer someone and get an appointment in the next few days. And so that was sort of the genesis of the next body of work.
Great. And before we get to that, just to think about the landscape of palliative care at that time, we had the Temel paper in 2010, which showed that in advanced lung cancer, specialty palliative care in an outpatient palliative care clinic setting improves quality of life at 3 months. My research mentor, Camilla Zimmerman at Princess Margaret in Toronto in 2014 did the Lancet trial, which showed that not just advanced lung cancer, a bunch of advanced cancers, early outpatient palliative care can improve quality of life at 3 months. And then your 2016 paper said, well, advanced cancer, but not just in a outpatient setting, in the ED. So I think it was the first trial in the ED of specialty palliative care said, we can improve quality of life at 3 months. In that paper, so I think the intervention, if I remember, it was a specialty palliative care team. So there was a physician, nurse practitioner, social worker, chaplain, and they were consulted in the ED and followed as inpatient. Is that right?
Yeah, so the consult was placed in the ED. At that time, there was no overnight palliative care. At Memorial, we have 24/7 palliative care. That definitely
Yeah.
was not the landscape at that time. So if they were admitted in the evening, and the palliative care team was not available, they would be seen the next morning. but as soon as possible. And then they would be followed if they had ongoing needs. It was up to the palliative care team, but it was a holistic consultation in the sense that there was no specific question like, can you treat the pain?
Yep.
It was, do a comprehensive assessment, and it's, to your clinical judgment, whether you think they need to be followed on a daily basis and referred to outpatient or not.
Okay, so some of them got kind of daily follow-up, including outpatient follow-up. Some of them may not have needed that. Do
Exactly.
you remember what was the average length of stay of patients during that trial by any chance?
Yeah, it was very variable. So, so the standard deviation was huge. I couldn't tell you the range exactly, but there were some patients that stayed for weeks. There were some patients that were discharged, in days. And what we did note, though, was that a small percentage, less than half, got palliative care consultation in the control group,
Okay.
but they got it much later.
Right.
So, I think it was something like 5 or 7 days later.
Right.
And so that was a missed opportunity, right? So that was the
Right.
interesting thing, is it wasn't like no one got it in the
Yeah.
control group. They just got it
Yeah.
much later in the hospital stay, which is kind of what we still see today, right?
Yes, absolutely.
In some ways, yeah.
And it's amazing that uh, even though about half of them in the control group got it later, you were still able to see a huge significant difference between
Yeah.
the quality of life at 12 weeks. And that amazed me that the inpatient stay, I doubt the average inpatient stay was 12 weeks, or that they
No,
got
no, no, no,
follow-up
no.
for 12
Yeah.
weeks, but you could somehow project whatever the intervention did over a short period of time to some difference in quality of life at 12 weeks, which is amazing. And at that time, is completely new finding, because all the trials of outpatient palliative care followed patients monthly, including at the 12-week and at the 6-month. And so there's a explanation for why it would have improved quality of life at that period. So it was amazing that you were able to show that there's some kind of persistent benefit that these patients receive. So
Yeah. And for something that's so simple to do as an emergency physician.
yeah, exactly, just to send the consult.
Mm-hmm.
So that was amazing. So that paper came out, and what we would have hoped for was, like, policy leaders and others who make kind of decisions on funding might have seen this and said, specialty palliative care makes a huge impact in the ED. We should fund specialty palliative care to be available to everyone in every ED. But unfortunately, that's not what happened. So that's what
No.
led you to this paper. And your question is, specialty palliative care, we know, works when initiated in the ED, but it's not accessible to everyone.
Mhm.
Can we make a less resource intensive, more accessible palliative care that provides the same kind of benefit, right? Is that kind of what you were thinking about?
Yeah, it was a primary palliative care
Yes.
intervention. So the idea was, you know, most patients, if you guys have gone into an ER, they're not there between 8 and 3 p.m. They
Yeah.
start coming at 3 p.m.
Yes.
And so we really need the emergency medicine group that, nurses, social work, physicians, APPs, students, residents, to really have the primary palliative care skills to do, because they're like the front line.
Yes.
And so that was the idea. Yeah. We had
Okay.
another trial that started a little bit beforehand that was funded by PCORI, that we haven't published yet, but we presented at AHPM. And that's about, what if you discharge someone? What are the models of care after discharge?
Right.
But we'll leave that
Yeah.
aside for now. But this was really
Yeah.
focused on the experience of the patient with serious illness in the emergency department during their stay there, not after they get discharged, not once they go upstairs, but like,
Yes.
because the emergency physician is the holder of the disposition decision. So
Yeah.
they get to decide, is the patient going home? Is the patient going to observation? Is the patient going to be placed in hospice? Are they going to go to the ICU? Yeah, so
Yeah.
that was the idea.
Yeah, for sure. So let's get into this more recent trial. Um, we'll talk about how it differs from your 2016 trial. We already talked about the intervention primary palliative care, and I'll bring Kristen in as we talk about kind of the differences. So the participant group, let's start with that. So in the 2016 trial, the participant group was patients with advanced cancer, which, as we said, in the landscape of palliative care, that's what we were looking at that time. And there's a more interesting question: what about other patients with serious illness who come into the ED? So, Kristen, can you speak a bit to kind of what we were thinking about related to the participant group in this trial, and our question for Dr. Grudzen?
Yeah, for sure. First of all, thank you so much for even having me here. Just seeing you guys talk is like amazing, and an amazing learning experience for myself. So I'm so grateful. Yeah, so the first thing, I guess there's like two kind of points that we had in terms of the population. But we were looking at other studies, and there was a variety of mortality prediction models that people were using. So our first question was, why specifically did you choose this Gagne comorbidity score of greater than 6? And how can we ensure that all patients with unmet needs, palliative care specifically, are being included within this threshold? So yeah.
Okay, I'm so impressed with your question. First, you pronounced it the correct way, the Gagne.
I was
And your
practicing.
question is so important because we couldn't, right? Is the answer, is the simple answer. And I think that is a great point. When you do, this was one of the big differences between 2016 and what we did here was it's a pragmatic trial, which means instead of 150 patients around that we had then, a little bit less, here we had 100,000 patients we were in this intervention. And so we couldn't do palliative care needs screening. We had to come up with another way of identifying people who we thought would have high needs. And so what we did is we used the Gagne, and we chose that versus the Charleston comorbidity or anything else just because it was the best predictor in the setting. It wasn't that there's evidence from the emergency department, but it just had a better predictive value than other measures, and it was easy. And yeah, we just looked at basically the predictive value of it, and it had the highest. And so it's just a comorbidity count. And so it looks at claims from the prior year, and it says, okay, this person has dementia and coronary artery disease and hypertension, and so based on the count of conditions, you can predict the mortality. But you're absolutely right. There could be someone who maybe is diagnosed in the ED or just, doesn't have prior evidence of disease, but is incredibly ill. And sometimes those are the most vulnerable patients, right? They haven't even seen a doctor, but they show up, when I worked at Bellevue Hospital, they show up with, very, very advanced disease with no prior visits. So, you're absolutely right. I think it did a decent job of giving a population-based sense of the sickness of the patients. In the sense that what we found is that cancer hospitals had the sickest patients based on the Gagne, which is not surprising, but you don't think, so we looked at a place like MD Anderson, which was part of our cohort of EDs, and that had the sickest patients. And it does make sense. Like my experience now working at Memorial is that when you work in a cancer ED, that I've never seen a sicker group of patients because they all have cancer. And so versus a regular ED, you have patients with bumps, bruises, fell and hit their head, or, suicidal ideation that need a psych consult. So when you pre-select patients with, advanced disease or just a disease condition at baseline, the patients are quite ill. So yeah, that's a great question. I wish I had a better answer for you in the sense that we could do a better job of doing that. But I think going forward, those are kind of the systematic changes we need, is to identify those patients with patient-reported outcomes, not just, claims data.
Yeah, that makes a lot of sense. You explained that like perfectly as well, and that's kind of what I guess I and we assumed as well. You were talking about like the Charleston Comorbidity Index, and I think the Gagne was kind of adapted from that. And I think it fits well your population in terms of the practical barriers to that. The second kind of follow-up to the population as well was, and you already mentioned more so for practical reasons, but including kind of patients with a short prognosis, we kind of mentioned that it might exclude those with a longer prognosis, but still people who have unmet palliative care needs. So a lot of what Dr. Matthews and I were talking about is this push towards a needs-based approach. So looking at symptom severity, patient reported outcomes, which you mentioned. But again, have you considered that? And was it more so the practical barriers to kind of using that approach?
Yeah, well, I'll say, just to back up for a second, what you're referring to is the analytic plan, but we didn't so the emergency physician would identify the patients either on their own by kind of just as they, I think it's obvious as a clinician and even as a student when you go into the room and you see someone is very ill and has palliative care needs, they're in pain, just all the things that we do as just human beings when we walk into a room and see that someone is clearly very ill and has advanced disease. It's kind of obvious, the eyeball test of like, you can see it. So nothing prevented, the skills are applicable to all those patients, right? What we did is we gave people the skills, the technical assistance, the workflows, and made it as easy as possible to identify patients with palliative care needs and or make the documentation part, prior documentation, easy to find and put in alerts to say, this patient has advanced disease, have a conversation, or this patient has documented preferences, read about them, or they have orders for life-sustaining treatment, here they are. So there's the approach in the ED, and then there's the analytic plan. We didn't tell anyone working in the ED, hey, there's this Gagne score, and we're going to put an alert when the Gagne is over 6. Like, that was our analytic plan to identify, to see if there was a difference in healthcare utilization in patients at high risk of short-term mortality, because we assumed that that's where we would see the difference. But you're absolutely right. We may have been looking, first of all, at the wrong cohort. Maybe it did make a difference in a different patient population that had 3 years to live. And so actually, that's a very astute question, because maybe the findings of the trial, maybe our cohort was not correct. And no one has actually brought that up. That's a brilliant question, truly, because maybe it was these patients with high short-term mortality, maybe they had to be admitted no matter what. And maybe we should have looked at some other less sick group, and maybe it did make a difference in that population. But it's very interesting. Yeah. But to go back to the emergency physician in the ED, we were just trying to really give people the capacity, the skills, the training, not just by education per se, because we know education doesn't change behavior, at least in the short term. But yeah, change people's hearts and minds and sense of their own abilities to do this work. So they could do it, in any patient. We didn't say you had to be Gagne, or they didn't even know what the Gagne was. Yeah.
Right. I just want to highlight that, the fact that you were able to do a palliative care trial with 100,000 patients is just amazing. Like, if, Kristen, the average specialty palliative care trial has like a few hundred patients. I mean, I think Dr. Grudzen's 2016 paper had like 130 participants or something like that. And so this is, amazing and, fantastic that they were able to have a palliative care trial with 100,000 patients in, I think, 29 EDs across the US. What is it like to plan a trial like that, even to bring a team together of people from 29 EDs to think about, okay, what is our intervention going to be? What are our outcomes going to be? Can you speak a bit to that?
Yeah, we're doing one now in 80 emergency departments, like
Wow.
in dementia, which is an even more complex intervention, because we're doing a similar primary kind of palliative care in the ED, but then it has all these other arms. And I would say you have to find friends at these
Mhm.
places. You guys are both now friends. And I think find people that are really passionate about this work, like yourselves. That's the only way you can get it done. And to build those relationships over many years, in fact, decades, we've built them.
Right.
So some of the work that we did in the trial we're discussing, the emergency medicine talk or the communication skills training, we developed that whole curriculum as a group of very passionate emergency physicians. And so that work in healthcare systems all across the US. So we tapped into those people, and it's a small community, as you know.
Yeah.
And so really relying on relationships and people passionate about the work. And it's a small world, so that's really the best way. We did most of the design of the intervention and the measurement and analytic plan ourselves, because many of these folks at these healthcare systems are leaders in other ways, but they're not necessarily researchers.
Yep.
Some of them are, absolutely, but many of them are just master clinicians, master educators, and really change agents, but they don't necessarily have research skills training in the sense that they would be the ones to do an analysis or propose an outcome. I mean, proposing outcomes anyone can do, but you get
Yeah.
my point.
Yeah.
And so, just using people for the talent that they bring, which everyone has different ways to contribute. So those ways are absolutely critical.
Great. Okay, so let's come to the intervention next. So the intervention in this trial, as you mentioned, it's a multi-component primary palliative care intervention. It looks like it has four components. One is an evidence-based multidisciplinary education. There's you talked about the serious illness workshop, clinician decision support, and an audit and feedback. Can you speak a bit to that intervention? Kind of what was the evidence base for the education, and what was the clinician decision support and the audit and feedback
Yeah,
process?
sure. So we really stole shamelessly. We paid the people that developed many of this curricula. And it's meant to be train the trainer. So much of this work was done by other people. So, for example, LNEC, the end of life nursing education curriculum, that was developed decades ago with funding from the National Cancer Institute. Betty Farrell and others developed that. And is evidence-based and really is meant to have trainers go and attend these sessions and learn these skills and then go back to their institution and train others. And so that was the nursing curriculum was taken from that, and it's very effective, absolutely has been shown to be effective at changing provider or nurse behavior, and nurse education and training and pre-post and that kind of thing. I don't know that there's evidence it changed healthcare utilization, but absolutely um, help nurses obtain the skills and yeah,
Knowledge
that
and
they
attitude.
need to do this work. So that was the nurse training. And then the licensed independent practitioner training was called EPIC, and that was developed by a team at Northwestern, and they had an emergency medicine module. It's called EPIC Emergency Medicine, that was developed decades ago and also had an evidence base and was funded by the National Institute on Health. Um, and trained independent practitioners, APPs. It was mainly developed for emergency physicians, but they also had trained chaplains and social workers and other people that work in the ED. So we use that both of those were asynchronous, so you could do them on your own time, which was really important when you're training thousands of nurses across the country and hundreds of doctors and APPs. We needed some asynchronous component. So that was the asynchronous part, that was really just getting the skills and the knowledge there. And then we felt that there needed to be also a face-to-face, whether that's virtual face-to-face like we are, or in person, literally sitting in the same room practicing and learning communication skills. And so we use the Vital Talk methodology, which is simulation based using patient actors. And so we had all of the clinicians go through that 4-hour training, which was a challenge in the sense that we trained hundreds of people, and we needed to have trainers that had gone through a very extensive training process to teach. And then we had to hire actors that were already in the system. And so that was the reason we did it as a stepped wedge, because it was so human resource intensive to deliver this training. So that was the training and the skills training and the asynchronous learning. And then the third component, clinical decision support, we made a trip to all these institutions, and we sat down with them and said, this is what we did at our pilot site at NYU and at Rutgers in Newark. This is how we changed our electronic health record. We can give you all the codes. You can just input the same clinical decision support, or you can say, hey, our population is different. We want to do it our way. It was really meant to be tailored to the local environment. And so, we learned a lot during the pilot phase so we shared our swim lane diagrams and our code, and now there's even more advanced ways of doing that with things called turbochargers. If you're on Epic, you can simply give someone a turbocharger package, and the technical specialist can take that code and just basically run the same pathways in their own local electronic health record if you're on Epic. So we didn't have that at the time, but we're able to really provide a lot of support to the local IT teams to either implement exactly what we did or tweak it to their population. So for example, UMass had a high population of advanced heart failure patients. So they felt that was a really important population to identify for goals of care conversations in the ED. And so we had a way of sort of alerting the emergency physician to those patients. Versus at NYU, it was really identifying patients on hospice who were already on hospice, who had prior, in New York, we call it medical orders for life-sustaining treatment, or the MOLST form, who had, because we had these cases basically where people would come to the ED, they would have all this documentation of prior wishes and preferences. No one would be able to find it or see it or identify that this patient had done all of this work, and they would get resuscitated against their wishes. And so that was what we were really trying to avoid. So that the clinical decision support was to identify, patients with prior wishes. We did have one alert that identified patients with advanced disease to say, hey, this patient has high short-term mortality. You might want to have a goals of care conversation. They don't have prior documentation that we can see. That didn't go over so well because it's time intensive. And so we ended up taking that alert down at NYU and focusing more on prior documentation to identify that easily for the emergency team. And then the fourth was audit and feedback, saying, hey, you have these alerts. We've given you this training. How are you doing? Are you admitting patients how is your admission rate in patients with advanced disease? How many cases are you referring to hospice? How often are you using the palliative care specialty consult team? How often are you using case management in these situations? Or so that was the way, these cases are not always frequent. And so we ended up doing the audit and feedback typically at the level of the ED unit and not at the level of the provider, because if you're working in a cancer ED, I now can give people individual feedback about how they're doing in terms of referring to hospice. But in a regular ED, general ED, it's very difficult. These cases don't necessarily come on every shift that you work. And so we generally had it at the level of the ED, and the leadership team would look at those metrics and give feedback to people on individual cases where, hey, you didn't see that this patient was already on hospice. How could we make it easier for you to identify them? So.
Amazing. That it's such a massive intervention, at the level of 29 EDs, and the fact that you didn't just implement a cookie cutter kind of thing, but you tailored it to each ED and their unique patient population and what they needed. It's just an amazing amount of work that would have gone into that, right?
Yeah. We felt it was important to let
Yeah,
people tailor it. That's a lot of
yeah,
the research on implementation science and
yeah,
pragmatic trials is you can't, we can do a cookie cutter. It allows us to find a difference where we want there to be one if we try to make everyone do what we want them to do and we protocolize it. But
right.
then in the real world, it doesn't end up making a difference because we all do whatever we wanted to do anyway. So
Yeah,
you understand.
yeah,
Yeah.
of course.
Yeah.
Okay, Kristen, what questions did we have regarding the intervention and the control group?
Yeah, mainly it was around the control group if
Yeah,
we want to move on to that. Okay.
yeah,
Yeah, so moving on to that, I know that you used the pre-intervention group as your control or comparator group for this study. And we know that like in many studies, we like to compare, or in many trials, we like to compare our intervention against the standard of care, which you've kind of proven in your 2016 trial and in other trials that that's specialty-based palliative care, or in the ED at least. So we were wondering whether you considered, or did you consider using specialty-based palliative care as your control group, or what was your reasoning behind using the pre-intervention group from a methodological standpoint?
Great point. Yeah, so in step wedge, each ED or unit of randomization serves as their own control, and it gives you a lot of power because basically, you deliver the intervention. We did it every 3 weeks at a different ED over 2 years, and so we could look for many, in some cases, years at what was the admission rate before we delivered this intervention. And then we also had all that time afterward. So it's a pretty statistically powerful way. But then we had this global pandemic that came along and really there were temporal trends then that happened to coincide exactly with our study. And so it's a whole other conversation. But yeah, so we decided to use the baseline as our control because this was a pragmatic trial. We really identified with the sites. There was no way specialty palliative care could have seen any fraction of these patients. And the whole idea behind the study was we don't have enough specialty palliative care providers. We want to upskill the emergency group to do primary palliative care. And yeah, so that it just was a really practical, feasible issue of feasibility. Yeah, if we could have designed it as randomizing EDs at the same time to either control or intervention rather than each site serving as its own control, that would have been more ideal. And we actually went back and forth about that at the time. But because the only reason really you should do a step wedge is if you can't do the intervention at all those sites at the same time. That's the whole reason the step wedge came about, was really you have this intensive intervention. You want to do it across a whole bunch of health systems, generally, or clinics or EDs or provider groups, and you can't deliver it. It's not humanly possible.
yeah.
And so that was the reasoning behind that.
Yeah, so it sounds like a few of the decision making around, the intervention, the control group, the population is based on practical, like what's possible when you're doing a
What's
study with
possible? Yeah.
29 EDs and 100,000 participants, and we'll talk about that when we talk about the outcome as well. But I'm interested in like a hypothetical question. So suppose this wasn't, a study of 29 EDs, but just your ED where you do have access to specialty palliative care. And suppose you want to ask the same question: is primary palliative care by upskilled ED clinicians comparable to specialty palliative care? Would you think about doing such a trial with specialty palliative care as a control group, as a standard of care?
That's very interesting. I think, um, I think we know, I feel I know the answer to that question, which is specialty palliative care is always going to be
Yeah.
better than primary because sadly, we don't have really any trials that have shown that primary palliative care is effective. And we have so much work that shows that specialty palliative care does so many wonderful things. And so I don't know that that trial would have even been funded in the sense that, I mean,
yeah, even from an ethical perspective, I think the way you could justify it is if you say the population is going to be kind of a population with kind of basic symptom needs,
yes,
no complex kind of symptoms.
yep,
So for that patient population, can we ask the question like primary palliative care versus specialist palliative care? So you're kind of optimizing a limited resource for those who need it the most.
that's so interesting. Yeah,
Yeah, which
super.
is kind of what a lot of palliative care trials are trying to do now, like to say,
Yes,
how can we kind of back off the resource intensiveness of
yep.
specialist palliative care, right?
Yeah, take the
Yeah.
more simple cases and give them to someone
Yes.
else. Yeah,
Yeah.
yeah.
Yeah. Exactly. Okay, so I think we'll finally now come to the outcome measure. So,
Mhm.
Kristen, do you want to talk a bit about that and what we were thinking about?
Yeah, this was I guess, the main outcome or like the main thing to me that kind of stood out as to why you chose to use hospital admission for your primary outcome. And you sort of alluded to this saying just keeping it kind of focused on what's happening immediately and not kind of after for this trial at least. Yeah, so many studies have used kind of quality of life as the primary outcome. Was it more so, again, the practical barriers of collecting this information? Did you have the quality of life kind of during this study to include that as maybe even a secondary outcome?
Mhm.
Or, yeah, so what was your kind of decision making around sort of the outcomes of the study as well?
Yeah, so we thought about quality of life. I think given the nature of the study, it would have been almost impossible to get good patient-reported outcomes and this number of patients. And my guess is we would have had differential missing. The missing data would not have been missing at random. It would have been missing in the patients that are the sickest, and we would have patient-reported outcomes in the healthy patients. And
Yeah.
so I think there were a whole bunch of biases it would introduce into outcome measurement. And so with studies of this size, I think until we get to a point where patient-reported outcomes are measured and available in everyone, which, like I said, in cancer centers, they're much more readily available. So I think it's an interesting place to do this kind of work because it's a more closed unit and follow-up is much better. And we were dealing with patients with all kinds of illnesses who were popping in and out of different health systems. And it's a much more complicated group. But yeah, so part of it was a practical decision. And also, I did believe at the time that it's something we have control over as emergency physicians. What I didn't, I think it was a big ask. It's very difficult in the current state of our world to, especially during the pandemic, there weren't a lot of resources in the community. So where can you safely place someone? You can't send someone home if there's no one to take care of them, if there's no home resources, if there's no hospice that's going to come, a hospice nurse going to come and see them the next day and make sure they're okay. If there's no facilities to go to, and there's no community resources. So I think that was the complicating factor is we tried to build those up and we went when we went to each health system, we said, let's have a really robust collection of resources that the social worker and the case manager and the ED know that there's a hospice partnership that we can send someone and it's reliable and or community-based organizations that can help. And despite doing all that, I think there just weren't enough resources. And so even if someone felt, okay, yes, I think it's the best place for this person is at home, I still can't discharge them if it's not safe, right? So it was too much to ask, I think. Sorry. Okay.
Okay. And Dr. Grudzen, what was the mean length of stay in the ED before like a disposition was reached? Was it like a few days, a day, or?
Generally in the ED's disposition, so they could either discharge the patient home, which is done within hours, and definitely not. But many of the EDs, not all had an observation unit. And so that was an outlet, a place where that counted as in our analysis um, as a not an acute care admission.
Okay.
So it counted as being outpatient, because in the United States, if the way our health system works, if you're placed in observation for a day or two, you're still considered outpatient.
Right.
And so that was like a release valve in the sense that that was a safe place someone could go for a day or two if we were trying to arrange home services, hospice, home care, PTOT, anything we could get, or a family member to come in and help. So we were hoping that kind of safety valve would help allow people to go home. Um, didn't work out that way, as you know, in the
Right.
trial, but
Right. Yeah.
yeah.
So, yeah, as you mentioned, it was a negative trial. We didn't see a significant difference in the primary outcome. And I heard you mention at another in another podcast that you weren't surprised by the outcome. Can you speak a bit about that, and at what point did you think that, oh, this might not come up as a positive trial?
Yeah, I think at the time of writing the grant, I was wondering, I think I wasn't sure. Yeah, I was hopeful. I think I'm overly ambitious, as many of us are. I think that's like part of our downfall is we think we can do more than we can actually do.
Yeah.
So I think it's part of the cup half full and this excessive optimism. And then the reality of the work, once we got into the pilot work, I thought, wow, is this the right outcome? Is this really even possible? And I think, and then the pandemic hit, and there were even less options and less community resources, and I think that's when I think the work became even more important, but the outcome became more difficult to achieve, if that makes
Yeah.
sense. Like,
Yeah.
I think the trainings were so well received and came at like this critical time for
Yeah.
emergency clinicians and nurses. But the outcome became more difficult. So it was kind of ironic because the nurses, the physician, everyone was so passionate about this work. And, it was like you could feel the enthusiasm, but at the same time, they still admitted the patient because there was no nursing home beds available or there were no hospices going into the home. So it became pretty clear that, to me at least, that this probably wasn't going to be effective. And also the population changed. Everything changed, right?
Right.
The
Of course.
the patients coming into the ED completely changed. No one came in unless they were so ill that they had to be admitted. So almost every patient that came in got admitted because if you felt like, we kind of laughed. We said, what happened to appendicitis? I haven't seen an appendicitis case in a
Yeah.
year.
Yeah.
Like, did they just stay at home and they did okay on their own because they just avoided coming in? Like, no one came in that didn't need to stay. And so I think it was just such a total transformation of the healthcare system. Yeah, but I don't know if we really learned our lesson, because this new trial we're doing now, we're looking at revisits as our outcome, which is also hard to change and a little bit out of our control. But
Yeah.
yeah, so we're trying again to do something near impossible. But
So this reminds me of a lot of the literature on advanced care planning. So when you look at the
mhm,
literature on advanced care planning, and if you pick the outcome as subsequent goal concordant care, it shows the same thing. You
yep,
never get a person who wants to die at home who actually dies at home.
yeah,
And so one way of looking at that is to say, well, advanced care planning doesn't work. We should all stop doing it. The other way to look at that is say, maybe the outcome isn't goal concordant care subsequently. The outcome should be satisfaction with care, feeling prepared for the future. So
yep.
my question is, like, did you ever think that satisfaction with care or the hundreds of clinicians who were upskilled in this way, their kind of learning satisfaction, their knowledge, like these could be the primary outcomes in such a intervention?
Yeah, and we did measure all those things and they're published, but they're not published in JAMA, so no
Right.
one reads them.
Yeah,
They're
yeah,
smaller qualitative studies, and we looked at some implementation outcomes, and we have a whole bunch of other papers about those things, but it's hard to get those into JAMA, as you
yeah,
know. But I think, yes, so I don't feel the trial was a failure for the exact reasons you said. I know in my heart of hearts that this improved provider satisfaction,
yeah,
meaning in their work, that it improved communication in some instances, but you can't, and Randy Curtis, rest in
mhm,
peace, is the one that told me, you shouldn't measure quality of communication because patients always rate it and families rate it so high, you can't get it
right,
higher.
right,
And so I know that we improved communication in certain cases. I knew that wasn't the right thing to measure as the primary outcome because we had no hope
yeah,
of improving that. But I know that it improved in certain scenarios because it's like a study of a parachute. We just know that it
right,
will
yeah,
prevent,
yeah, yeah,
we don't need a
yeah,
study of parachutes or no
yes,
parachute. Like
yeah,
we just know that if you've ever gone through the training or have the communication skills that um, you can just see it right in front of your face, that it has face validity.
yeah,
And so I still feel training hundreds of doctors and APPs and training thousands of nurses had huge impact.
yeah,
But yeah, so that's the fun work of pragmatic trials is you still get to have the satisfaction of doing work that's meaningful and that we know that has an impact, even if the study is not statistically the primary outcome doesn't
yeah,
show that.
yeah. Kristen, did we have any other points about study, the outcome, anything else?
No, I think that was mainly it. We talked about
Awesome.
a good amount, yeah.
So, Dr. Grudzen, when you think about both these studies together, the 2016, 2025, both ED-initiated palliative care, what are the conclusions you draw, and like, what do you think, people should take away looking at both these studies together?
You guys are so thoughtful. So I think first message is easy, like put in a consult to palliative care if the patient's being admitted. It is just so easy to do. If you have any inkling that they would be helpful, they can even just do a one-time consult. It just gets the patient at the beginning of the admission to have this extra resource. And so I think that's a no-brainer. It's easy. We know it improves quality of life months later.
Yeah,
I think I'm not ready to give up on primary palliative care interventions. I think, we have more work to do.
yeah,
Clearly, you know, I think specialty palliative care, it's not surprising. You have people like yourself, Dr. Matthews, who have decided to make this the focus of your life's work. And of course, when you have an audience of the willing and excited and you spend a year doing this or more, in some cases doing specialized training, you're going to have a different result than if you have people that may or may not be interested and that only get, hours or a day of extra training versus a year. And so I think maybe the dose wasn't right. Maybe we need to increase the dose or um, make the resources more available. So maybe develop interventions in which we really change the operational flow in a sense that we make it easier for people to make the right decision. And
right.
I'm trying to figure out how we do that in the emergency setting. I think if patients go home, we can give them resources and sort of change the mindset about how different groups provide resources, but I don't have easy answers. But I think I'm not ready to give up on, yeah, primary palliative care. I think there is a way we can do it. It just maybe the dose needs to be higher.
And not only are you not giving up, you're going even higher, right? You're going to 80 EDs now.
Yeah.
Is that what is next for
Yeah.
you?
Yeah. We're focusing on dementia, which is a really challenging population, I think feels for emergency physicians, very scary and time intensive. And it's like, oh my gosh, it's so hard to get the history. And it just feels overwhelming for the emergency physician, especially if someone comes in with high needs, difficult to get, the information or the history, and they feel like at a loss for how to even approach this population. So yeah, there'll be plenty of work for all of us to do for decades to come to try to figure this out.
Amazing. Uh, Dr. Grudzen, thanks for your time. Was there anything else you want to share that we haven't covered about this trial?
I don't think so. I'm just so grateful that you guys reached out and you asked such thoughtful questions. And I think it was last week, the Jerry Powell podcast got
Yes.
released about the
Yeah.
trial. So I would just
Yeah.
say that's another way
Yeah.
to hear about it. But I think this forum is, yeah, very rigorous. And I really hope that you end up pursuing this, because I think, yeah, this is just a great way to take different learners. And Kristen,
Yes.
you've been so
Yeah.
thoughtful with your questions.
Yeah, I was gonna say, like, even as a new, like, researcher myself, it's so nice to see such expertise from the both of you, from like both, you know, actually advising the study to how you talk about the outcomes. It was really, yeah, important for me to see. So thank you.
Yeah, thank you both. This was
Amazing.
super fun.
Yeah.
Great. Thank you. Thank you so much for your time.
Have a
Yeah.
great weekend. Take care. Bye.